Today is Monday, August 10th, 2020, and my name is Natalie Kimball. I'm interviewing Luzs Muñoz for the Voces Oral History Center at the University of Texas at Austin. So we want to inform you first that this interview will be placed in the Nettie Lee Benson Latin American Collection at the UT of Austin. And if there is anything that you do not wish to answer or talk about, that's completely fine. I can honor your wishes. And if there is something that you do want to talk about, please bring it up and we'll talk about it. Because we are not conducting this interview in person, I need to record you consenting to the interview. So I need to ask you a series of 5 questions, and just please say, yes, I agree, or no, I do not agree after each one.
Okay.
There's a couple of questions that we need to start with first to make sure that you are comfortable with them before we go on. The first is that Voces wishes to archive your interview along with any other photographs or other documentation that you may wish to share at the Benson Library, which is at the University of Texas at Austin, and we will retain a copyright of the interview and any other materials that you donate to Voces. Do you give Voces consent to archive your interview and your materials at the Benson Library?
Yes, I do.
Excellent. Do you grant Voces copyright over the interview and any material that you provide?
Yes, I do.
Great. Do you agree to allow us to post this interview on the internet where it may be viewed by people around the world?
Yes, I agree.
Excellent. So these are the other few questions. We had many questions already that we talked about in that pre-interview form.
Okay.
We use that information from the pre-interview to help in research. So the entire form is kept in a secure server at the Voces project. And before we send it to the Benson archive, we would have stripped out any contact information for yourself or your family members so that it will not be part of the public file. Your public file is only accessible to the Benson Library. Do you wish for us to share the rest of your interview in your public file available to researchers at the Benson?
I believe so. Yes, I do.
Okay, great. And then finally, on occasion, Voces will receive requests from journalists who wish to contact people that we have interviewed. And we only deal, in this case, with legitimate news outlets. Do you give consent for us to share your phone numbers or your email with journalists?
Yes, I do.
Okay, great. Okay, so that's the preamble portion. And the first thing that we just like to ask is if you can tell me a little bit about something that's bringing you joy in these really difficult days.
Yes, one of the biggest things I believe that bringing me joy is the ability at work first, the ability to be able to recover little by little, getting back the units to the normal state what it was before COVID, and giving the patients the safety environment that they deserve and they require to be able to recover. That is in work related. Personal related is my family, and I don't have kids of my own, but I have my nephews and my nieces that are my join, and actually be able to see them. I have 3 small kids and 3 small babies that they growing, and being safe, that's one of the main issues that's bringing me happiness and joy right now.
Oh, good. I'm so glad. So I know in our pre-interview, you talked a little bit about your background, that you're from Lima, Peru.
Yes.
So if you want to just say for the interview too, just a little bit about what your upbringing was like and where you're from originally, and then where you're living now.
Okay, good. Yes, I came originally from Lima. I went to nursing school in Lima, Peru, in the Army Hospital. I graduated as a BSN in Lima, and I worked for a little bit in Spain, Madrid, and then I came to New York. In New York, I sit for my state board, and I passed, and I started working as a registered nurse at Lincoln Hospital in the Bronx in 1993. From that, I moved to Elmhurst in 1999. I came in initially as ADN, Assistant Director of Nursing. In 2002, I became the Associate Director of Nursing for the evening and night shift. And about 2004, I became the Director of Nursing for the evening and night shift. I was running, working between evening shift from 1500 to about 23:30 and overnight. I worked from 1999 to 2006 in that role. And in 2006, after graduating from my Master in Public Administration, I became the Associate Executive Director for the Medical Surgical Services, which include the critical care area, all the ICUs, nursing rehab, and also the hemodialysis unit. From that time to now, I'm still in that role. I supervise about 25 nurse managers and head nurses, in addition to about 600 employees between registered nurses, LPN, PCAs, clinical staff that reports directly to my division. I am responsible for the whole nursing, clinical and administrative roles and responsibilities. I have 5 educators under my direction that report directly to me. We look at the evidence-based practices to lead the clinical nursing skills of the staff. Basically, that's what I do. Mm-hmm. I do hiring, recruitment, hiring, and responsible for education for clinical outcomes of the whole division. I have about 280 beds in the medical surgical, included 29 bed ICU and regular medical surgical units, rehab, and surgery units, surgery beds.
Wow. And can you walk me through sort of a day in your life at work prior to COVID-19?
Okay, so our day, my day is it's a little busy day. I come usually before 7 o'clock. Sometimes I do round on the units to see the night shift staff even before I report to the nursing office. Nursing office, we usually report at 7 o'clock. We meet with the night supervisor that give us report, and we recollect whatever overnight events, and from that we plan the day, what are the issues that need to be followed up. Then I usually meet with a manager in the nursing office who is responsible for the staffer, the whole medical surgical units, look at the staffing of all the units, and look at the clinical issues that need to be followed up. That is between 7 and 8 o'clock. About 8:45, we do an interdisciplinary meeting in the nursing office where all the disciplines are represented, engineering, maintenance, environmental services, social worker, other nursing disciplines, and our CNO is usually leading that meeting. So to discuss all the issues that went over and the issues that need to be addressed immediately, like a room, is broken or need cleaning, a special cleaning, and so on. There are issues clinical issues that need to be referred to different disciplines. So in that meeting, we discussed that. From that, we, on Mondays, regular Monday, 9 o'clock, from 9 o'clock to about 10 o'clock, I meet with all my managers to go over the issues from the weekend. Clinical issues, administrative issues, and any issues that need to follow up and need to refer to different disciplines. From that, we actually, day-to-day, the operations of meetings to try to improve practices, meetings to try to see that any issues, the regulatory agencies that we need to follow up, and meeting with my CNO or this CEO of the hospital to see issues that need to be followed up. Normally, that goes along the dates. The planning of the clinical skills of the staff, meeting with the educators if anything that need to be followed up, and with the managers to look at issues, clinical and administrative issues of every single unit. Normally, we have 100% communication during day-to-day with the nurse managers and the head nurses. Issues that need immediate attention is referred immediately to me, and we can escalate the issues where they need to be done. I round in the units, many times meet with patients and families to see how the care is being done and what we can improve. So that is most of my day.
And can you tell me a little bit about when you first heard about COVID and what that was like?
When we first heard about COVID, it was something that was far away, but it was coming in our way. So we started to prepare for it. We started to look at the first, we did search capacity, how many patients we can accommodate, where we can accommodate. This, was in collaboration with central office and with every other discipline. Our disaster management plan, we review, we see what we can do, identify spaces where we can put patients if we need it. Then looking at the clinical needs of those patients, the competency of the staff, review clinical practice as the proper use of PPE, going around and doing competencies with the staff, in services to review practices, and organizing the classes when you have 100% capacity hospital most of the time. That's what we have, to try to ensure that all the staff get to the training in timely manner. Is a lot of coordination. So we started doing that. We started to prepare in coordination with the 4 educators that we have, the nurse managers, and we constantly review anything that came from CDC, anything that came from our infection control department, from our central office directive. So we constantly try to communicate with the staff and try to apply whatever we learn from anything that came, especially what we hear from Italy that was going on, and then our central office directions. We try to follow as much as we can and really put to the staff, the whole staff, through the in-service that was needed to get prepared to receive these patients. So one of the things I can tell you that we say that, well, that is far away. Maybe it's not going to happen to us. Maybe it's not going to come here. So we trying to get ready as much ready as possible, but we also thinking about, no, it's not going to get here. So that is one of the things that, we try to deal with in a very realistic manner and try to ensure that all the staff went to training, education, but with a hope that will never get here. And I can tell you that is the reality that I was hoping.
Mm-hmm. So it was really at work, the first place that you had heard spoken of COVID-19.
Yes, at work and through the news, through every single communication means that we hear there. But directives specific to our workplace was given to us from central office and at work.
Okay. Does any particular moment stand out to you about, hearing about this pandemic and beginning to realize that it was going to be bigger than you hoped and more disruptive than you hoped?
The first time that when we heard that the first case appeared in New York in Westchester, is here, actually is here in New York, still with the hope that it's not going to be as bad as it was. One moment stand to me is the time that we got our first patient in our medical ICU. I can say the traumatic event, even though we were getting ready, we were preparing very, very seriously and realistically preparing. We got the first patient, and I think the shock and I guess no reality. We didn't want to accept that it was here. Many of our staff got very afraid to deal initially with the case, with the patient. We were ready, but not ready at the same time. We have transportation services, the patient that were a little scared. We have the staff that was scared to go into the rooms. We have to support the hand and say, okay, this is what we're gonna do it together. And we give on the spot in services, and we were there with the staff most of the time to try to overcome the stress that they were having to receive the first patient. We saw cries, we saw tears, we saw desperation from the staff because they were very scared, even though we were preparing. The first day, I remember that we got the patient on almost 1, 2 o'clock in the evening. We prepare the staff. We have a car outside of the room. We have the papers that we need to do. We in-service the staff. One of the staff actually volunteered to take the first patient. And then after that, the night shift came. The staff who came in, one of the nurses were really crying and say, please, don't let me go inside the room. I have small kids. I remember that very clear because it broke my heart. But at the same time, you know that this is what the job we signed for. So I explained, and I stayed with them, and I said, I have to explain to them, okay, this is a test. As long as we follow the practices that we learned to, our proper use of PPE, and we have people next to us observing what we do, we're gonna be safe. Of course, trying to overcome the seriousness of the events, this first patient. But I will always remember the faces of the staff, and even though we tried to give it an assurance that it's gonna be okay, we wanted to believe it is gonna be okay, but after that it went so fast, really fast. After that, we moved into 1 patient, 2nd patient, then 10 patients, and after that, you just became a whole unit, COVID unit. And suddenly we have to move patients from regular units to another units to try to convert the units one by one into a COVID units. So it was something that we were supposed to be ready. In reality, I think no one was ready for what came. It was really like, I hear this, it was really like a tsunami. It came to us. We were trying to get ready, but we did not get ready per se. Emotionally and psychological, many of the staff were very, very affected. In addition to many other operation activities that we needed to get in line to be able to facilitate the care of the patients. Okay, environmental services, transport, nursing, physicians, even the morbidity and mobility and the patients that went through fast, that really emotionally was a big burden for the staff, for each one of us. We tried to cope, and initially, even though we prepared to see who is gonna go here, who is gonna go there from our own staff, we prepare our staff to work in med search, to work in a step-down unit. We normally do that, prepare them to, it is needed, the staff will go to the step-down unit. and the step-down unit staff will go to the ICU to work. We have 24/7 competencies that we do for the staff to be able to prepare them to work in higher level of care units. And we did that normally even before COVID. But during COVID, this came so fast that whatever we have in place in normal basis, it was not enough. It was not enough. It was really more demanding. My first unit that became another ICU was my step-down unit. A 35-bed capacity step-down became in a whole ICU. Staff starting to getting sick, starting to get afraid, many of them not coming to work. So staffing issues became an issue the first 3 to 4 weeks until we finally got agency staff or travel agencies to help us. But the first 4 weeks, it was really very skilled staff, clinical, demanding for all this staff. We have to relocate staff from the regular medical surgical units into the step-down unit, but the step-down unit was not in step-down unit, was in reality another ICU. So the staff used all the skills that we provided through the whole years, but still was not enough because it was really ICU. We went from a 29-bed ICU with 3 ICUs that I have to 169 ICU beds. In a very short period of time. In 1 week, we moved to open a 35-bed ICU. In another week, we converted most. We have about 280 beds in the medical surgical unit, so almost every single unit was a COVID unit. And the patients that we have that were stable, that were no COVID, we borrow a place in one of the other divisions, mother and baby division, and far from the medical floors and the 8th floor, we borrow 1 bed and we make it that unit a 16-bed non-COVID patients, and that's the only thing that we have as a non-COVID. Everything else became a COVID patient. So during that time, the staff, to be able to care for these patients, did whatever they could done to do the best. One of the issues is we started having, no visitors. No visitors was very traumatic for the staff and also for the families. The ability to properly communicate with the families and reach out to them, because the phones keep ringing, and at every encounter there was a family member inquiring about the families. So we try to assign people to respond to those phones at the very beginning because the staffing issues was chaotic. But later on, we did have a group helping healers to heal and help us to answer the phone, to connect with the families virtually so they can see the loved ones and they can talk to them. We were able to accomplish that a little later after the peak time was very difficult because there were so many factors, so many demanding issues that the first priority for us was to care for the patient, to save the patient, to try to stabilize the patient. And then later on, we focus on the family to try to help them with the families. So the first week, when I'm telling you our emergency room was overflowing of patients, we did not have too many beds until we make those beds available to those patients. We started getting our admissions one after the other. Many of the units that we closed to make them ready to receive COVID patients, initially we have to prepare the rooms, to prepare the PPE outside the rooms, to prepare to receive those patients, oxygen and so on. When patients were coming from the emergency room, sometimes they came a little bit agitated, exhausted. They get to the beds and they were, air, needing more air. and so on. The staff needed to hold the hands and really spend time and trying to tell them to calm down, to breathe. Okay, we learned new techniques like proning the patients. As soon the patients got to the units, okay, we try to hold, please lie down in your belly. Try to breathe in, try to breathe slowly. Learn to try to, as much as we can, to avoid intubations. We did work as much as we can to try to prevent the patients to get respiratory distress and intubation. I remember clearly a patient who was about to be intubated. The anesthesiologist was at the bedside, and we proned the patient. We told the patient, please lie down in your belly. He was very scared. He didn't want to lie down in the belly because it is more effort. They feel like they're gonna drown. So we were able to help him, and he was not intubated. He was discharged home later on, and it was, a lot of work from the staff to try to calm the patient, to put it in the belly, to give it oxygen, and to spend time holding the hand to help them to breathe. We went through many events like that. They were so very serious. So I can tell you a lot of things that went through these moments. Many of the staff really, they were very, very sad, very depressed. We have many increase on emergencies that we need to accommodate 2 or 3 emergency cars in the different units. And the staff needed to divide it to respond to the different emergencies to try to save the patients. Even though we have 169 ICU beds, we still have to hold patients in the regular units waiting for an ICU bed. So the staff and the competency and the skill became very important during those times. In the regular medical surgical units, we hold those patients until they get a bed. Managing drips, managing ventilators, and with the support of the head nurses, the nurse managers, the nurse educators. And one other thing that I really want to also mention is what our rapid response team, that is nurse practitioners that responded to across the whole med-surg unit, really facilitating the care and preventing the patient deteriorating more and more. We work together with interdisciplinary team, doctors, nurses, respiratory therapists, every single person, I think, gave 100% of our training, our skills to try to care for the patients in the best of our abilities, what we have on hands. So, yes. I don't know if that I respond to.
No, absolutely. That was very comprehensive. One of the things that struck me while you were speaking is, so you kind of walked me through a day in your work life prior to COVID, and now you're kind of unpacking all of these really intense circumstances and some of the challenges you all have faced. I imagine that was also increased in hours for you. Like, if you could explain to me a little bit about how your daily work just changed with all of this, and how that evolved over time.
One of the biggest things in our role is, in my role as a director of my services, is to try to, number one, first in this circumstance is to communicate. And communicate when everybody's busy and is not, hello?
I can hear you just fine.
Okay, I think lost the, okay, got it.
Okay.
So I lost the, so communicate, like I say, communicating is not easy because nobody is really at the desk. In these moments, everybody is out in the clinical area and trying to really work with the staff. So my day, I can tell you that it's definitely coming in early, before 7 o'clock or 7 o'clock, going through every single unit, We try to round in every single unit, even the managed and head nurses are there, communicating the changes, because there is a constantly change of practices, of instructions, especially infection control instructions. I don't know you hear, but there were many changes from the CDC that come every single day. Every single day was something different, and we needed to get that information to the staff. First, the PPE. We initially say we need N95. No, we don't need N95, and so on. So it was, full PPE, no full PPE, eye cover, no eye cover, face shield, no face shield. So there is many changes, and we needed to ensure that the staff is safe as well. They practicing nursing and medicine in a safe manner. So trying to communicate that first, going from unit to unit, rounding and trying to get on the spot instructions to every single one of the staff. Then the other issue was preparing to receive or to discharge patients. Preparing to receive patients, we needed to ensure that every room, has the door, has a PPE out of the room, has the phone that is working, have the bell alarm that is working. So we created checklists for the staff to guide themselves into how to prepare a room to receive COVID patients, how to prepare a unit to receive COVID patients, how to discharge patients, how to prone patients, because proning, a new technique that is proven to be very effective. So how to ensure that the patients who are in no rebreathing mask, that they needed to go to the bathroom, don't just pull it out and go to the bathroom and then they suffer that oxygen is needed. So we needed to ensure that by rounding and looking, we need a commode at the bedside. So creating all practices according to what we are seeing in daily basis, we needed to adapt new techniques and new practices, like I say. So my day went many times from 7 o'clock to 11 p.m. or 12. There are days that, my boss and myself, sometimes we have gone home by 1, 2 o'clock in the morning and coming back at 7 o'clock. So it was a need, because it was a need to work hand to hand with the staff, to be there for them, to guide them that this is what is needed right now. And we, as a leaders, needed to show that we are 100% with them. And that's what we did. And that's what I did. So, I'm sorry.
Go ahead.
I just rounding and just guiding the staff, and many times just listening and being there with them, seeing your physical presence, it does make a difference on the morale and the ability to really go above and beyond, because that's what the staff really did. Really went about and beyond the call of duty to ensure that the patients are taken care. Now, there are many times that, especially at the beginning, our resources were scarce. Our resources, staffing was one of the issues until we got help in traveling nursing. But at the beginning, so it was more necessary for leaders to be present and to be there and to work hand to hand with the staff.
And in terms of outside of your work life, so one of the things that Voces is interested in is knowing how this pandemic may have created challenges with respect to finances or the documentation status of you or your family.
One of the issues, I am single. I have no kids, but I do have a elderly mother that we are 4 brothers and sisters, so we take care of my mother. We alternate on the weekends. During this time, I could not go to see my mother, and I could not take care of my mom. And I do have a sister who has cancer, so she could not be close to my mom as well in this because the exposure and so on. So my two brothers um, alternate and took care of my mom while I couldn't go at all. I didn't go to see to my mom about 8 weeks. For 8 weeks, I did not even got close to her house. Number one is um, I was 100% exposed here in the hospital. Everything was COVID. Number two, my mom is elderly, and I could not uh, uh, take emotionally the blame that I brought it home. I brought it to her, or I brought it to my sisters, to my brothers. So um, I live in New York. My family live in Jersey, but every weekend we go. So really, it was very emotional, detrimental, and also you feel guilty because you cannot go and help your loved ones, and you cannot go and help. My two brothers alternate to stay with my mom during the time. In addition to that, she did have a home attendant, and the home attendant got sick. And she lived by herself with a home attendant. So the home attendant was not available at all, and I was not able to be there to support that. So my brothers and my sister took care of her until another sister came. So it was, I can tell you, I was busy at work and as my focus 100%. In the other hand, my mother was one of the issues, and I was really concerned. And you feel guilty because you cannot help your family. So that's another issue that I can say it. I experienced that, and I know through talking to my staff, that's another issue that many of them went through it. I have some of my male nurses that, they took the opportunity that was given to us from our central office, the hotel accommodations, so they chose not to go home, not to expose the family. Through the whole entire pandemic and the crisis here, they did not go home. Many of my staff, they stay in hotels, eating, the food that sometimes given here, sometimes buying. They did not see the loved one for a long time. And I think more than financially, because um, I am I am a person that believe, and I say, since God, we did have a job. We never lost right now our paycheck. We never lost financially. I think we were stable. Whoever worked for the healthcare system, it was more than ever needed the the workforce, but emotionally and family was detrimental and continued to be detrimental to the family, because we always scared about if we're gonna bring it home. If we, even though we try to ensure that we do follow all the infection control practices, and whenever we get home, uh, we dress up here. We dress with our uniform, our PPE, and so on. We change before we go home. We take a shower before, and as soon we get home, everything what is in the hospital at the door is at the door. I put it in a plastic bag and go to the laundry. I know that many of my staff do that. I do that. No shoes brought into the house. However, still the issue that you always concern and always worry about bringing something home to the family. So emotionally is really a very big burden to the person, to the emotion, and also to the loved ones. I can say financially here, like I said, we would stay. Um, but what we went through, um, losing patients, and um, during the emergencies situations that we lost many patients. That definitely affected psychological to all of us. The ability also to provide the staffing, the right resources, the right PPE, the emotional support um, to 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 everybody who work here, because not only nurses, doctors, EBS personnel, environmental services, material management. We lost 5 people in the hospital from our supplies, material management, 2 people. We lost one nurse. We lost total 5 employees that we lost in the hospital, and every single loss is one that is our family. That was very significant, and also every single day when we got to the peak days, and we have patients who went into cardiac arrest, one after the other, respiratory arrest. Um, every time you hear the overhead page, and is we call it here TIN 700, is cardiac arrest. So we hear overhead that TIN 700 and so in floor. TIN 700 is also to the point that was really very, we didn't want to hear that anymore. No one of us want to hear that anymore. And now what it has stayed with us. Every time that we hear that, it's like uh, you feel something in your body, that in your mind you are scared that you can go back to those days. We did have a support group here for the staff that is called Helping Healers to Heal, a beautiful group from the psychiatric department, who did focus group with many of the staff after the peak time. They first went and individually talked to the staff, and then they did focus group to try to help in healing. And it was beautiful, but many of the staff is still hurting, and hurting a lot, because the people that we lost.
Right. And that's terrible. You've lost 5 at your own hospital. Can you remind me the name of your hospital again?
It's Elmhurst Hospital, ELMHURST.
Right. And you said you live close by, right?
I live like about 10 to 15 minutes away from here. I live in Maspet.
Mm-hmm. In terms of, you were speaking a little bit about your family as well, and just the emotional burden of that and the fear of bringing it home. One of the questions we wanted to know is if you have any family still back in Peru and other parts of the world, and how they, if you do, how they are handling and suffering through this pandemic.
I still have a family member. As a matter of fact, I have one of my sisters that came for vacation in March 2. She still cannot go back home because the pandemic. She initially was in Houston, Texas, with her son, and when my mom got without one attendant, they did everything possible for her to come. So I told you that my brothers were taking care of her. Then my sister came, and since there until now, my sister still had limitation to go back home. She's a social worker there. She works there, so she's very concerned that she cannot go back home. So that's number one. Number two, I do have a brother and my nephews back home. And also, I have a very good relationship with some of my friends in Peru. I know how it's right now in Peru, but during the time of crisis here, my family and my friends, they were very, very concerned. It's almost in daily basis, or if not, at least every 2 days, they either text me, WhatsApp, or call me and say, just to say, how are you doing? Are you okay? Are you taking care of yourself? And it is very rewarding that you hear from people even that you haven't heard for a long time, but they were concerned. And right now, the situation in Peru is very difficult. Through the news, I understand that they are in a very, very hot spot. And I'm trying to do the same. I'm trying to communicate with my friends to try to find out how is it going over there. My family, thanks God, are okay. It haven't been touched, and I hope we continue like that. But every single day they are. So one of my nephews is also there. He's from here, but he's waiting to be able to come back. And other nephews that are staying home. I staying home. Financial wise, it is definitely very difficult to try to maintain the family with no work. So uh, definitely the situation in Peru is now is very hard at this point. I don't know if I answered your question.
Yeah, absolutely. Yeah. Are you, you talked about sort of impacts to your family, including, difficulty of not being able to get together with them. Do you have any sort of relationship with your neighbors? Like, how has your daily life outside of work changed? Do you still go out to get together with anybody? What does life look like for you outside of work?
Um, very little time I saw the work. However, I do have a neighbor that in normal basis probably I did not visit a lot or I did not see it a lot. During this pandemic, it's an elderly person that lives across my house. Um, I think it's 2 days, I can say two. In one weekday, I say I gotta come early home because I gotta see how she doing. So I make myself available, and I came home like about 5, 6 o'clock, and she normally sitting outside in her porch. So after I shower, I clean myself, I put my mask, and I say I'm gonna go and visit her, just to spend some time to see how she's doing. As an elderly person, she sits outside, so she knows what is going on in the neighborhood. So she is telling me what is going on here, there. So I spend like half an hour talking to her and listening to her because she needs. And I did that twice. I cannot say more. I did that twice. I do not have like a social uh, relationship with the rest of the neighbors. I say good morning, good afternoon, and basically that's all. Back in New Jersey with my family, we used to get every Sunday morning. My family gets together to have breakfast. My brother, I have one of my brothers who is a physician. He's a pediatrician, and because he is busy too, so he comes 8:30 every Sunday, and we get together to have breakfast, and everybody comes. Uh, However, during the pandemic, we did not even once get together because number one, like I said before, my mother. Everybody was very concerned about my mother, and we could not get together at all. Right now, we are alternating. We are now doing what we used to do before COVID. Still no safe. So we try to go like 4 of us or 5 and meet with my mom and alternate. We haven't got the get together that we normally have everybody in one place. We couldn't get it. We My brother did a barbecue a little bit on 4th of July outside the house, and we alternate, but we did not get together. So the social events that we used to do before COVID, we are still not able to get back to that. And I think it's going to be a long time because just this weekend, we are concerned. In New Jersey, some cases are increasing, and in New York, we keep it low. Still, we cannot lower the guard, like my brother say, we need to keep up everybody, we need to keep my mother safe. That's number one. The kids need to be safe, and ourselves, because we don't know. Um, we are in the healthcare field, my brothers, my sister, myself. So very conscious of what we do and we don't do. Whenever we get home at the door in my mom's house, there is everything there to try to disinfect yourself. Lysol, you have to put in your shoes, and there is hand sanitizer, there is bleach wipes and everything before you go, and you need to take your shoes out. You cannot go with shoes inside the house. So there is a strict measure that we have to follow.
And the kids that are part of your family, are they school age, and what does education look like for them since this whole thing began?
Yes. So we do have some of the nephews are college age, and there is only one that is school age right now. So they've been schooling at home, what is very difficult. And also, I'm gonna relate it to work, okay? Because my nurses, the nurses here, they say it is like having a third job, because they're working here full time, and over there at home is like having two jobs at the same time. Teaching kids at home is no easy. It's very, very stressful, and they have to juggle with life, with work, and with the kids. So, and I normally hear this from my staff about how difficult. In my house is only one of my nieces that is have the kid at home, is 8 years old. Um, it's been challenging to have them at home, and the other thing is that you cannot go anywhere, like to take them to the zoo, to take in this still, because there is a possibility that at any point you can get something. And to be safe, we go to the park to walk, but very far away from different people.
A question that I have, you've talked a little bit through these different phases, sort of not very explicitly, but I hear what you're saying of like, there was this buildup in your work and in your community, and then the peak and the wave, and that now you've sort of suggested we still have to be really careful, but it sounds like things aren't as awful as they were perhaps a bit ago. And I'm just wondering if you could talk me through that a little bit more, and then also maybe project what do you see happening in the future in terms of work and anything else that occurs to you in terms of how it's been impacting your life.
Okay. So one of the the biggest issues, the wave per se, it came, stay here for about total of 8 to 10 weeks, and it started decreasing in New York. We're starting to getting back a little bit to normal with cleaning the areas, getting ready. At work, at home, the same thing. Disinfection of the house, the cleaning of the house, and everything was more rigorous during the peak time. The same thing in my mom's home. So now that in New York we are a little better, and New Year's we're starting to decline in the sense that we getting a little more lowering the guard, but not completely. Like I said, in my mom's house, we don't meet as before with a big table and everybody sits on the table. We are like 10, 15 people. Right now, we probably meet 5 with my mother, and so on. We don't do those gathering together at all. One of the concerns is that still the infection is here. Still, we need to educate a lot of our community, because you see through one thing that I wanna bring back, and it's related to this, is during our peak time, it was very sad. couple of days I drove, my house is by the park. I drove by the park like about maybe 6 o'clock p.m. And I can see gathering of people without masks. And, you know, the situation that we're going through, it was very detrimental that anytime that I saw that, my tears fell through my eyes because I say, how can they don't realize how difficult it is? How can they not realize that people are dying because this? So I was sad and really angry about the fact that the people did not understand how serious was the situation. So going back into the same issue there is that right now, the infection rate in New York is less than 1%. In New Jersey is 1.2 still percent. And I'm talking about the two states because I'm related to the two of them. My family is there and here. We try to be conscious and try to, as much as we can, follow the rules. Follow the rules when we are with people, we put our mask. Even if I have 4 people in my car and 4 of them are my family, they still wearing the mask because we are 4. Okay. We follow everything about hygiene, hand washing, hand sanitizers, and so on. You still see a lot of people in the parks, a lot of gatherings with no following the rules. So I do not know what is going to happen, but what I can say from the top of my heart and from really is that many people don't believe that this was true. Many people don't know what we went through here. Many people don't hear or did not see what happened. What we saw and what we experienced here, it was reality. It was painful. It was detrimental to the human being that we couldn't do anything to save many people. Okay, so every day, when I encounter with somebody who do not believe, there are people, believe it or not, that don't believe that COVID is true, that COVID is real, that COVID took many people's life. And they can argue with me saying that, oh, the people that died is because they have comorbidities, because they were sick, and I can say, no, there were many healthy people, and especially at the beginning, many young men. They came because men, again, I believe one of the things that happened at the beginning, men believe that it was not true and it couldn't get to them. They still were going to work. They still doing different things. And at the beginning, we did have a lot of male patients, that young people that really came. They were affected by the virus. Some of them recovered. Some of them did not make it. So what we saw here was reality. And that is always in my mind, in my heart. And I always pray for things not to happen again. And I don't think it's going to happen again because we are supposed to be more ready. We are preparing. We are trying to learn, and we learn from what we went through at the beginning. Even though we thought that we were preparing for what was about to come, we were not ready. And it got us by surprise. And hopefully, if anything comes, we are more ready because we learn a lot. We learn around every single day. Okay, and we're learning from everybody who went through this. We're getting experiences and trying to avoid anything that will come back. It will come back. I don't know, but hopefully, if something comes, it will be in less magnitude than it was at the very beginning. And I really think that if this comes back, it's not going to be like it was at the beginning.
I'm
That's good.
sorry. That was something on my phone came through. I had a feeling that might happen, and I don't know how to shut it off. When would you say that things felt the worst? Like was it in June, in July?
No, I can tell you, we have our first patient here between
So sorry.
uh, February 27 and March 2nd. This is the first patient that we got in our MICU. The following day, we got the second patient in another isolation room in the MICU MICU. Follow that the next week, we got 6 patients into what we call it an E7. We converted a unit next to the MICU, and we still have patients that were not too critical there. I'm talking about the second week of March, we started realizing that the patients were coming sicker and sicker and sicker. By the end of March, we saw that it was real. April, the first week of April is when it really went through probably the whole hospital. April, second week, third week, and the fourth week of April, then we started getting help. The traveling nurses and so on came, but I can tell you between the third week of March to the second week of April, okay, up to end of April was our worst time here. Definitely our worst time.
And I was struck by what you said about the young men. I mean, this could be, one of the things that I work on as a historian is gender and sexuality, and sort of the ways that men and women, what goes into making femininity and masculinity, and how perhaps they think they're less at risk, or that they're less likely to seek medical care, who knows, or that, as you mentioned, they continue to go to work. And I was just wondering if what your sense is, in not necessarily specific numbers, but of the patients that you lost, their general ages and numbers, and men and women.
So I can tell you that at the very beginning, I'm talking about March, second week of March to about first or second week of April, we saw most of our patients were young males, okay, with no comorbidities. Okay, no comorbidities, many of them coming in, maybe have underlying issues, but they probably were not aware of. Okay, we have 32, 39, 42, 49 years old. I can tell you in that period of time only, maybe from 4 admissions, probably 3 of them were male, okay, that period of time. After that, that changed. After that, more to April, May, we started seeing now medium-aged persons, male, female, regardless of, and by the end of May, probably, we started seeing more elderly people. Now, what it was in relation to what other countries told us that, this happened more to elderly people with comorbidity and so on. At the very beginning, we did not see that here. At the very beginning, we saw young male patients, mostly with no comorbidities. During the peak time, I can tell you probably an approximate, like I said, from 4 patients that we admit, maybe 3 of them were male and 1 was female. Okay, and by the end, it became more like the general population, where they were saying that elderly people with comorbidities starting to come, but at the beginning not. And I think it's because what you say, male tend to say, no, this is not going to happen to me, are more out there, they're less careful in the sense that, infection control, no, I don't know the other reasons, but that's what we saw here.
And the project is also interested, I remember you said in your pre-interview that you didn't have any particular experience directly with the protest movements, but I was wondering, in terms of your life and your work, did any of the social movements that went in conjunction with this whole pandemic, did it impact your daily life or your work at all?
I don't believe so. You know, we started seeing the protests of in Manhattan and so on, in Queens, almost at the end of our peak COVID times here. But we did not see an increase in relation to the protests. We did not see an increase of patients with COVID. We were expecting to see that because we say, you know, there was the protests that were all together and so on, but we did not see, as far as I know, and as far as my recollection, we did not see an increase. It did not make an effect in the amount of patients that we're getting in relation to COVID. No.
Okay, and is there anything else that you want us to understand about your experience with this pandemic?
One of the things that I really will emphasize again is what we saw and we live here. It really was reality. We saw many patients that came. Some of them, you know, in the way that did not have different comorbidities. Maybe they waited a little bit too long to get to the hospital. They came in distress, in respiratory distress. They got to the emergency room, then they got to the floor. We got them in very, very severe effort to breathe. And every effort definitely was made to try to save the patients and to get them back to breathe normally. We apply every single technique that we learn in school, every single technique that we learn from our other hospitals, every single technique that we learn from other places. We try to prone the patients, we try to give oxygen via nasal cannula, we try to work with the patients to try to improve the breathing, because when you in stress and you scared, of course, it's gonna demand more oxygen and you're gonna be more desesperated. We try to hold and we try to make them breathe and try to calm them down to try to prevent them from, you know, going in more distress. The staff here really went about and beyond, okay? And with the resources that they have at the very beginning, they definitely work very hard with each one of the patients to try to get them better. Many of my staff got sick. Many of them got COVID. I don't know, again, if here in the community, this was all over the community, but many of them improved. I really thanks God, because I did not lose no one of my staff per se working here with me. We did lose 5 of our family members from the hospital, but every single person in the hospital, I think every single one that you will think of, work very hard and work as a team together to try to get the patients to save and to bring it back to the community, to bring it back to the family. We felt that every family member that were part of the patients, that we wanted to reach out to them, that we wanted to comfort them. We really did everything possible, went from patient to patient, trying to connect them with the families, trying to respond to the phone calls. And the best thing that happened to us is that we discharged some patients after 107 days, 102 days, after 98 days, patients who were being intubated and ventilated, who recovered and went home. It is the emotion. It is the first day that we did that, the patient went home. It really felt a blessing in our heart, and is really you cannot imagine the pain that everybody went through for each one of our patients and the families. But I can assure you that everybody did give 110% and did the best. And I think by the rate and by the statistics, by the numbers, the hospital staff did a wonderful job. Physicians, nurses, and every single personnel. I think I personally recognize the effort and dedication of all the staff. And I want to thank, especially the nursing staff that are under my direction, but, they really went above and beyond, and they did a wonderful job. And they continue to do that with everything what we have. I know we have a commitment with patients, families, and as a leaders, we also have a commitment with our staff. And I think that we have to be proud of them, that they did an excellent job in the circumstances of this. And we will continue to do that. We try to provide the resources, the tools. One of the issues that we did not talk about is, there was a lot of talk about PPE, okay, availability of PPE for the staff. I can tell you that during the crisis and the pandemic, I believe we never ran out of PPE. We have to limit the number, and we have to properly use the utilization of the PPE. But we did have, and we provide to the staff what it was needed. We have to control the utilization, and we have to sometimes, monitor and so on. But we did have the PPE that the staff required. We put systems in place to provide some of the requirement that they needed. Like, for example, we distribution points in every single unit. We provide big carts with PPE at the entrance of the units, because like I told you, we converted most of our units in COVID. So at the entrance of the unit, every unit have a cart with all the PPE that is needed. In addition to that, the managers were providing to the staff. In addition to that, after the disposable PPE per se ran out, we put a cart with a reusable PPE on exchange basis. Through my office, my secretary, the staff came and got the uniforms. They drop it in the dirty bin, and they got new ones. So in a constantly basis, there was a PPE for the staff. So,
in terms of, did you feel supported by local policies that would ensure you with PPE? Because it sounds like a lot of that initiative was taken by you and your hospital in terms of making sure that that was available. Did you feel like you were supported in terms of supply chain or any government agencies that were involved with that?
We definitely were supported by our central office. There were PPE was available to us. There was some back orders. That's at one given time there was back orders. That's we have to ensure that we properly use and not waste the PPE, but we did have it. On the other hand, one of the issues was, I told you that 2 of our staff from material management got sick. So one of the issues that some of the staff felt like, say, oh, we did not get enough PPE on timely manner. Okay, but we got PPE. Okay, maybe no at the 10 o'clock, but we got it at 1 o'clock at 2 p.m. So we got PPE in timely manner. So I think when we're talking about support, it's support from at every single level that our staff was able to get the supply they needed. No, in the regular way, like I said, the truth is, if we got an N95, maybe we have to use the N95 for a day, okay? Not like before COVID, you use one, you throw it, you use one, you throw it. No, during COVID, we did need to ensure that the supplies are properly used, okay? And many times probably reuse for the 24 hours period, but it was PPE available.
Mhm. Okay. Thank you so much for doing this and also just for your honesty and vulnerability. It's very clear that you care a lot about your staff and the patients, and I'm just so grateful that I had the opportunity to speak with you. If there's anything else you wish to share, we can do that, but I'm mindful of, we've been talking for longer than an hour, and I know you're very busy, so thank you so much.
But I just the last thing is, I just wanna thank you for the opportunity given to me to share this experience. I wanna thank you through my whole staff, the nursing staff, my clerical staff, my head nurses, my educators, and I say belong to my division, to the medical surgical division, and especially a big, big thank you to every single nurse manager and nurse leader from the division, because they were here as much time as I was here. They came early. They stay to 7, 8, 9 o'clock, okay, trying to support the staff. Even one of them got sick. He did not want to stay home, need to stay home, okay, for 14 days, 2 weeks, stay for about 10 days, came back to work. But every single one, I really want to recognize the nurse managers, the nurse leaders, the supervisors, and also the off-shift supervisors that really supported the staff at every minute, at every level of this crisis and every single day.
Mm-hmm.
So thank you for that.
Absolutely. Yeah, that's remarkable. And it will definitely, that thanks will be recorded. So thank you again.
Okay, thank you.
Okay.